go to work. Yeah, it was. Good call. You get that one? You get it, no, you get that one? Yeah, we're good on that. What got confused with this one? This one, I thought I went to the webinar, apparently I did it, so. There's a little door down below, right? Yeah, it was, and I thought I hit it, but maybe, I thought you hit it too. Yeah, but maybe I did. Computers are ones and zeros, man. So, they don't forget. But yeah. Possibly. Tony has a red person. Anyway, so this is up and running now. They have their slides. Webinar is recording, so we're good to go here. All right, let's move on to Azalea. Nope, there's nothing in either one. Yeah. No verbals in the belly, no verbals in the mouth? No. Perfect. Yeah, that's pretty good. I'll be there. Here, for your purchasing.
Timekeeper.
Okay, do you have your things for timekeeping?
I do not.
No, okay. Now you. You have 4 presenters, so we have, so it's 4 presenters, the total amount of time is 15. That includes presentation and Q&A. And then there's only 3 presenters. I can't remember which are that 3 presenters, but maybe 20 minutes. And just clarify with your speakers if they want you to like hold up the time or when they're approaching, because usually we need to tell them like we have 12 minutes to present and a 3 Q&A. Just confirm with them how they want you to designate like the amount of time.
Okay, sounds good.
Yeah, and if you've got questions, send them over on file.
Okay, thank you.
Thank you. And I'll make sure your moderator is in a second just to check all the slides.
Okay. Hello. Yeah, I didn't want to present this. Hi, I'm Leanne, I'm retiring keeper. Nice to meet you. Yes, so. But I can just kind of, when you so will monitor.
We'll take slides that we
Okay.
right. And 1, 2, 3. So I have updated.
Oh, I see.
I already took
On your drive, let me just check with it and see where.
Yeah.
Oh, yeah. I think I'm on the. Yes. Yeah, you should, as long as you, I can copy it now.
Yeah. Same now, so.
Yeah, I'm the presenters. Yeah,
Great.
I did some presentations. I need to copy it on the whatever machine. Should I email it? Is it easier or?
We can copy it if you have in your.
I do. They said use a USB, but I mean, okay. Yeah. I feel like email might be safer for your machines. Or
Yeah, I think,
But
yeah, she's got it right now. So. And just a quick technicality question, so I didn't put it like, early about 15 minutes.
Yeah. That includes.
Yeah, hold about 30 minutes
Yeah.
for the whole 15 minutes or like at 7 minutes or sorry,
Well, 9 because you want me to stop at about 12, right?
yeah.
So that there's 3. Oh, wait, so your 3 minutes more will be, okay, no.
Just
you're-
up to you, preference,
Oh,
yeah.
okay.
Yeah.
Yeah, well, yeah, let's limit me to 12 talking time. Yeah. So you go 3 at 9 minutes and then you can go 1 at the 11 minutes.
Yeah.
Then you can just start.
Okay.
Yeah.
All right, thank you.
Is Alauddin, how I pronounce your name?
Yeah.
Alauddin.
Yes.
I'm going to be the moderator and the rest of the presenting this. Just to make sure I pronounce your name.
Just a quick technicality question. So it's 15 minutes for each presentation, 15 one by, so there are 12 minutes. And then should be 39. Would you, I think it's most time.
In terms of. So you want us to, how this will stand here and vote?
Yes, that will be better.
Because of the light.
Yeah. Which one is your original one? So I can do it.
This is, you guys, this.
Oh, that's the only
Yes,
one.
yeah, I didn't email it in, so
Oh.
it's fine.
Sure, you're the second. Yes. And 15 minutes.
Yep.
It's a timekeeper, Q&A.
You don't have to go to this. Yeah, I know.
I'm just gonna ask you, so that might also get the. Okay.
So yeah, so you can list it right away. How I.
Yeah, perfect. I just, yeah.
And start calling. I love the.
Oh, you got it?
Yes, you can.
I'm looking. I have a lot of colleagues right now that I'm working with, and even my past life, a lot of colleagues and collaborators on the project.
Yeah, we can add more chairs.
Oh, Mathematica Policy, it's like a economic consultant.
Yes, we can. Still have a problem. Could you please, write them, or you can sit here and share the mic too. Which one is easier for you? Yeah.
What kind of capacity building you need? Institutional or technical engineering? It's because we mainly work with government and also Okay.
Yes, also, if you know what to. Right. So it's yeah, like.
Oh, yeah. Thank you so much. Yes, please hear about the stars.
Okay. Just like any urban. Right. Oh, I remember. I went. Five signs. I was working around I was supposed to work on seasonal migration. So when you go, what they call, yeah. So there is the man from we saw in this paper. People are actually that with that quite a lot. I mean, it's so funny. You want to we don't go that deep and important right there. First go always then try. Like when we have the ball have better connectivity.
We are about to start. Are we ready? Can you hear me? I think she did. Good afternoon. Thank you so much for joining us today in the behavioral change session. I'm really excited to learn from our great panelists today about the issue that I believe we all care about. So we are not randomly choosing this session, but I believe we all believe behavior change and also the issues that each of our presenters are going to share are important for us and also the health outcome that we are all hoping to achieve. So, particular interesting session for today is that we are not only focusing on behavioral change, but also there are issues about women empowerment and gender rights, that how it's all interrelated with the behavioral change in the war sector. And without further ado, I'm going to introduce our great presenters for today. First, we have Mr. Robert Dreibelbis from London School of Hygiene and Tropical Medicine, going to present about testing of behavioral science informed intervention to improve hand hygiene during childbirth in Cambodia, result from the CHAMP+ study. And second, we are going to have Mr. Ali Akram from Mathematica Policy Research, going to present about sustaining behavior change through learning in preventive health and experiment in Pakistan. And third, we are going to listen from Mr. Alauddin Ahmed from ITN-BUET about sanitation intervention and women empowerment, a comparative assessment of 2 cities in Bangladesh. And last but not least, we have Ms. Manyashal and Ms. Miraj from CARE International, going to present about addressing and measuring change in structural barrier to gender equality within the Federal Ministry of Water and Energy in Ethiopia. I think all of these presentations are really important and diverse. They're representing different countries in low middle income countries, and I think it's really important for us to give more time for them to explain and share their experience with us. And I would love to get really good participatory from all of us who are here today. And one important note, because we also have online audience, and if you're going to communicate with them better, it's to use the microphone. And if we have questions, to ask or wait for the microphone to be in our hands so the online audience can hear us all. And without any more delay, I would like Mr. Robert to present. We have 15 minutes, including the Q&A. Thank you.
Thank you. Hi, good afternoon, everyone. My name is Robert Dreibelbis from the London School of Hygiene and Tropical Medicine. I'm presenting on our study in Cambodia, trying to looking at improving hand hygiene during childbirth. I do want to acknowledge from the start the authors of this study, kind of particularly Elizabeth Tadiri, Liang Supip, and Nasim Sum, who were really the people who were driving this forward, who were leading everything, who've done all of the work, basically. I'm the one standing here. We're kind of some background here. Infection prevention and control is really critical, particularly during childbirth and postnatal care. Anywhere from around 10% of maternal deaths to about 15% of neonatal deaths are attributable to infection, most of which is acquired during this very critical childbirth and the immediate postnatal period. Improving hand hygiene during this period is actually a little bit difficult, though. What we see globally, not particularly just in low and middle income countries, but globally, very low rates of compliance with hand hygiene protocol. We also see more in low and middle income countries, systemic barriers to improvement, like lack of infrastructure, lack of supplies. And finally, the intervention models that we have are predominantly from very high resource, very high income settings. So how do we develop and adapt intervention models that are more appropriate to these low resource environments? Well, we tried that previously. I mentioned this is the results from the CHAMP+ study. And what this was building off of was the CHAMP study. The plus, I don't know what it was, plus time and another round of data collection or two. We did adapt the intervention. But the results here have been published in a few studies, but in brief, we did see with our initial intervention that midwives who participated in the CHAMP intervention were about 4 times more likely to have completed full aseptic procedure before starting specific events during childbirth compared to midwives who were in control facilities. Yes, there we go. Anyway. Things got a lot better, relatively speaking. But you can see here in the table, the control facilities at the top, the intervention facilities along the bottom. Overall compliance with hand hygiene protocol went from 24% in our control facilities to 14% at end line and 16% to 27% in end line in our intervention facilities. So while we did see a relatively large relative change, not necessarily kind of absolute levels of change that would really have us kind of confident that this is leading to public health impact. So we went back and we looked at our intervention and we thought about ways that we might want to improve this for another go. First, we wanted to make sure we had accessible infrastructure. Second, during the formative research, we found that midwives didn't really have opportunities for feedback to one another, particularly during labor and delivery. If you see your colleague missed a critical part of hand hygiene, they wanted a way that they could signal each other for that without directly in front of the patient saying, oh, wait, you didn't wash your hands, you shouldn't be doing all of that, because that wouldn't be good for anybody. They wanted more participatory and accessible training models. They wanted more practical application for the information that we were covering during the training. And they wanted improved visual cues to kind of prompt and get behavior to happen. And they wanted more opportunities for feedback to track their own progress and monitor how well they did. I don't know why that was animated, but here we are. So we redesigned, we went back to the drawing board with the intervention, and we sat down and we have two main components. The first is the intervention targeting the labor ward in particular. This is where midwives. Everything here was color-coded, this bright pink, which was also the color of the midwives' I want to call them uniforms, but that's not the right scrubs. Yes, the midwife scrubs were all pink, so it kind of fit. They chose all the colors. They had a color ranking board that they would fill in at the end of the day, where they would kind of talk about how well they thought hygiene did, and they would assign themselves the color and then talk about how they could improve that at the next day. We had these nudge stickers that were kind of around areas in the labor and delivery ward. Basically, anything pink were things that they needed to have aseptic procedure before they could touch them. There were some gray stickers that if they did touch them, that basically invalidated their aseptic procedure, not the stickers, but the objects the stickers were on, invalidated aseptic procedure. So we were taking kind of this implicit knowledge and trying to make it an explicit part of the environment itself. They had a word that they could shout at each one, mention to each other, which was recharge. And that meant you need to go and kind of wash your hands again and put on some fresh gloves, but without kind of alerting the patient to this. And then, yeah, we had new posters, this bright pink backing on everything. It looked really cute, I have to admit. I really enjoyed visually this intervention. And then a whole range of other activities we incorporated. I'll talk about that just a bit in the training module. The second part of this intervention was targeting the postnatal care area. Here, everything was color-coded within this kind of bright green color, which was again chosen for the midwives. There was a script for midwives that they were supposed, when someone showed up at the facility, they would walk everyone through, or the plan was they would walk everyone through a very specific script explaining that this was a clean hand zone. There were alcohol-based hand sanitizers that were on post, hooked to everyone's bed. Everything was green. Yeah, it was just kind of a way for them to introduce the concept of hand hygiene and share that with families and caregivers. Everyone had stickers if they had heard the training, kind of what you do with immunization programs. We put little stickers on everybody's vest so you know that immunization. We did that to know you've been someone talked to you about hand hygiene. We delivered this intervention over an 18-week period. One of the things we did want from our midwives for the first round is they discussed that there was too much training at one block in time. They wanted it spread out. So we adapted this from the kind of low dose, high frequency training modules. So it was kind of weekly or kind of 2 or 3 times a week, small components. They were about 10 minutes, 15 minutes. Some of it was online. Sometimes we were in the facility, but it was really, we kind of spread as much out over the intervention period as possible. And really tried to take advantage of everyone owning a smartphone or engaged in Telegram groups. And then for data collection, we had trained observers who were sitting in the birth area and the postnatal care areas, dutifully watching what people were doing and analyzing their hand hygiene. So, analytic part. This is where things have to get a little bit more complicated because the birth environment is a little bit more complicated than the domestic environment. And we had to have a 3-level outcome here. We have adequate hand hygiene. This means hands were washed with soap, clean gloves were worn, and potential recontamination avoided. So hands washed with soap, a new pair of gloves put on, and the midwife did not touch anything that could potentially recontaminate her hands. Second was inadequate hand hygiene. This means gloves were worn or new gloves were changed, but there was no hand hygiene that was involved. So we know this from a variety of studies is not optimal behavior. And then finally, we have invalidated, meaning no observed hand hygiene prior to a key event, or that the aseptic technique had been fully invalidated through kind of what they touched. And then getting it even more complicated, birth is not a series of individual events. It's actually a series of events that follow each other in a somewhat predictable sequence. So we organized these births and everything we watched into a series of flows, particularly the labor flow, which consisted primarily of vaginal examinations, the delivery flow, which is a whole series of events that occur often in rapid succession, and then newborn aftercare. We were particularly concerned that midwives started these flows with, that's where we wanted to see hands fully washed, clean gloves worn. We have other analyses that look at invalidation within the flow, but we were mostly focusing on what was happening at the start of these flows. Here's our participants. Won't go through all of this. We had at baseline about 26 births in each of our control and intervention facilities, and 21 to 23 births at end line in the study, which gave us quite a number of events to observe. So I'm going to do what I don't think anyone should do, is I'm going to start with the relative change here. What we saw, it's a lot of text. If you want it spelled out in the way that we're all taught to talk about odds ratios now, effectively in our intervention group, we saw a 16 percentage point increase in adequate hand hygiene at the initiation of key flows, and a 2 percentage point decrease in our control facilities. This was effectively an adjusted odds ratio of about 4.1, just like we saw before, relatively large confidence intervals. And then looking down here at the invalidated, we saw a 2 percentage point decrease in delivery flows with invalidated hand hygiene, but a 4 percentage point decrease in our control facilities. Ultimately, this is no real evidence of a difference, but we do see a relatively large difference within our control facilities, our intervention facilities. But once again, if we go back to the absolute change at baseline, focusing just on kind of adequate hand hygiene, in our control facilities, 16% of kind of delivery flows or any birthing flow started with adequate hand hygiene at baseline, and this went down to 15% at end line. In our intervention facilities, we started far lower at about 7%, but it only went up to about 25% in the intervention facilities at baseline. So once again, this really kind of, how do we explain, or we can't explain, it's math, relatively large relative differences, but absolute change here likely not quite reaching anything that we think would necessarily be at public health significance. And then in our postnatal care area, again, this is kind of where midwives were supposed to deliver the intervention. Really large text to say we didn't observe an effect. We didn't even do statistical analyses on this, just because in our intervention facility, we saw 3 people wash their hands with soap. Out of 500 possible events, which in the control facilities, we have 0 out of 600. So we did do something, but you can't do a lot with that many zeros. So there you go. Okay, so what did we learn through this whole process? Hand hygiene practices at critical moments were very low in both control and intervention facilities. The CHAMP Plus intervention, though, was associated with a large relative improvement in adequate hand hygiene at these key moments. Overall, kind of, with the kind of going back, I kind of moved over this quite quickly. You can see in that graph, the middle part of this, that invalidated hand hygiene, the kind of yellow in all of our figures, still remains the bulk of what we're observing. This is where kind of, mostly when we're seeing breaks in aseptic procedure, invalidation in aseptic procedure, a lot of that is simply changing gloves without subsequent hand washing, or double gloving, where a midwife will wear 2 pairs of gloves, and then when the outer layer becomes contaminated, whips off the outer ones and has a clean pair immediately under it. So it's kind of some of our challenges. But the relative size of improvements, very consistent with all of our other studies that we've done in this context and in other studies. So we wanted to understand kind of some of the barriers to this. And you had a series of key informant interviews with participants. We did see, at least for the parts of the interventions targeting midwives, they really liked the intervention. They were very participatory. We had really high rates of participation in all of the online groups. They understood everything they were doing, but midwives are making real-time decisions during a very critical medical window. They're often having to decide between providing certain aspects of patient care or going and washing their hands. So what's the actual, where do we need to calibrate what we're doing with this type of intervention? And ultimately, double gloving remains a very strong norm within this context. It is an ingrained system. And in the postnatal care, we saw incredibly low rates of participation. None of the midwives did the kind of nice tour. I think we had 2 or 3 out of everyone we talked to. The intervention was relatively just not explained to anyone. So, people were showing up to give birth in a very brightly colored environment, but no one was really kind of doing the other parts of the intervention that came along with it. But we need better delivery channels for people who are presenting in these healthcare facilities. I personally, slightly editorial comment, it's a little crazy that we're going to expect a midwife who's trying to kind of give, I did the intervention, so I'm pointing at myself here, someone who has a lot of responsibilities to then turn around and do a very kind of complex behavior change intervention, targeting particularly people at a healthcare facility. So we need better ways to deliver this. We're testing in the future, maybe having videos that are playing, but then that's a whole host of other options. So problems. So with that positive note, thank you. Yeah.
That was great, Robert. I mean, you've been working in this space for a while now, and I'm just curious, do you have any ideas for how to improve hand hygiene in the postnatal care rooms? And how much of a role do you think that plays in exposure versus the labor and delivery process where people are wearing gloves and at least that's a very critical event where people know that hand hygiene is important. And there's also a role of surface cleaning and just have you thought about this?
Yeah, we have thought about it quite a bit. I think particularly the postnatal care area, to me, becomes the hardest kind of nut to crack in this whole process. At least in kind of labor and delivery, we do see kind of 80% of events or more occurring with some type of hand hygiene. It might not be exactly where we want it, but at least it's a clean glove. In the postnatal care area, yes, but particularly in these environments, women in Cambodia, the average time that you're in the postnatal care is far less than 24 hours. It's, even a couple of hours. Immediately once you're in there, the entire family comes in. They want to see everybody's engaging. Until we have better ways to kind of support postnatal care full stop, I think these hygiene interventions are just going to be, there's a metaphor in my head, but I don't know what it is. I don't think they're going to do what we want them to do until we have much more comprehensive postnatal care for mothers and newborn children.
Truly, mothers are out of it right after they give birth. Just speaking as a mother.
Yeah.
I wasn't washing my hands before before
Well, so
putting my newborn to the breast. So, I mean, is there
Definitely.
a role there for an intervention point from healthcare facility staff?
Well, so the person the midwife was actually supposed to orient was the father or whoever had come with them with the mother. They had a special lanyard that they were supposed to wear. In the first round, we actually kind of left them out of it entirely, and we gave the babies a little hat
Oh, yeah.
that said, "Wash your hands before you touch me." And a very interesting poster that had a baby with a midwife holding the baby with a stop sign and all these hands kind of reaching for it. And it looked like out cut still, like some weird horror movie. So the visuals were a little bit tough to crack. Yeah, everyone hated the hat. I have never done anything before where all of your participants are like, "This is awful." So we dropped the hat, and we didn't use it this time. Yeah, but I mean, it was deliberately designed to like not necessarily make the mother the person who was responsible for that. I think we just, this is an environment where there's not a lot of ancillary healthcare staff sitting around kind of managing and making that environment more comfortable. So, yeah, I'm done. All right, cool.
Thank you so much, Robert. I think this is really interesting presentation, and if we have time at the end for those who still have questions for Robert, we can continue for the Q&A. We will move to the next presenter. Yes, please, Mr. Ali Akram. From Mathematica Policy Research, going to present about sustaining behavior change through learning in preventive health and experiment in Pakistan. Yes, we have 15 minutes, and Q&A is directly after presentation. Time is yours.
Great, thank you. I'll try to stay on time. So hi everyone, my name is Ali. I'm a senior researcher at Mathematica Policy Research. What I'm presenting to you today is my life outside of my 9-to-5. This is more labor of love. It's my past life, sort of still part of my current life. And so it's something I developed as a PhD student, and then with some really fantastic collaborators, built it out into its kind of version 2, as it were. So this is work that I'm doing jointly with Gabriela Fleischman at the Kennedy School, Reshma Hassam at Harvard Business, and Akram at Uppsala in Sweden. And so what is it that we're doing, and what's the question we're trying to answer? What is it we're trying to do? So let me give you a bit of background and motivate this a little bit. The question we're asking is, can individuals learn about the returns to preventive health in order to generate sustained behavior change? Okay. The preventive health technology, let me just put it out there, that we're looking at, the preventive health behavior we're interested in is water chlorination. The way we did it was, what we're doing is, and we're still in the midst of it actually, is a 4-arm experiment where what we're trying to do is separate habit and learning. Okay, so you learn the benefits of chlorinating your drinking water, or can we form some habit around it? The centerpiece of this is the learning intervention, which helps participants in our study track diarrheal disease and compare it to some reference level. And I'll show you what that is in a second. So that's what it is in brief. We're still in the midst of it. The timeline will make clear we're kind of, we're in the thick of things right now. And I'll show you a little picture of the timeline in a second. But the kind of the major contributions are that it's one of the few studies that really looks at very long run and sustained behavioral change from an informational and learning style intervention. We have a couple of guesses about the kind of learning that's going on. So there's a couple of, we explore that a little bit. And the thing that we're able to do is rule out habit formation. Okay? So with that said, let me get on with this. Where we're doing this is in Pakistan, in Karachi. Karachi is a big, noisy city in the south of the country. It's the fourth city, it's the largest. It's the neighborhood we're in is, it's a quote unquote, it's a slum, right? It's a urban informal settlement. It's poor. It's not connected to any infrastructure. The people there have to manage their drinking water themselves, right? They're on their own. Most people, more than 85% of people in this community do not have any do not effectively treat their drinking water, very much in line with the bulk of Pakistani households. There is no effective treatment. Water chlorination is at 2 or 3 percentage points tops. So chlorination, water chlorination is a great way to clean drinking water. It's low cost, it's effective, but people don't seem to take it up, right? Despite all these great things, there's very low uptake. And in Pakistan, it's abysmally low. Free distribution from a number of studies. I mean, the benchmark in my head is about 30%. If you hand it out for free, about a third of households will use it. That's in Africa. That's evidence from Africa. It may differ for our conference, right? Okay. So, wait. Did I want to say anything here? No. Okay. All right. So we have a 4-armed experiment going on. It's currently in progress. There's a pure control group, and then there are 3 arms that are being given chlorine for free. Okay, we're just handing that out to them. And it's actually 3 distinct arms within that active portion of it. There's a chlorine only arm, which is kind of like an impure control. It's an active control. There's the learning arm, which we call very unimaginatively the info tool arm. This is a name that unfortunately is stuck since my PhD days. I was thinking, I just wanted to call it something. So we were temporarily calling it an informational tool, which abbreviated the info tool. So this name is kind of stuck. So this is the learning tool that we're using. The third arm is an incentives arm, which rules out habit formation. Okay. So a total sample is about 1,800 caregivers and their young children. So it's a large sample. It's about 450 in each arm. 450 in each arm. Let me tell you a bit about what these interventions are. Okay. So one of them is this habit formation, the incentives one, the habit formation arm. This is based on work from one of the collaborators, Reshma. She did this in West Bengal and India with hand washing, actually. So the idea is very simple. Reward people for doing the right thing, right? So that's what we're kind of doing here as well. And procedurally, what that means is our health workers, we have this group of trained health workers who go around doing our protocols or doing our procedures. So they go to a house and to a household who's been given these free chlorine tablets, and the mother will present the wrappers from used chlorine tablets, and based on the number that have been used, we reward them. Okay. So what we do is we provide these redeemable tokens. There's things for children, right? Before we started all of this, we walked in and we found out what are things that are valuable to our community, and these were things that they said they want for their children. Okay? So the lowest value is stickers, but the highest value is things like backpacks and lunch boxes. So it's kind of proportionate to your use. Okay. I know a number of you are going, well, you can game it, right? And certainly that's possible. Although we think it's a little unlikely because we have been detecting chlorine in the water of these households. So it would be a bit weird that we're detecting chlorine and they're gaming it. Because if they just wanted to game it, they'd hand us a pile of wrappers and throw away the tablets, right? So there's other evidence that we have that suggests that we're probably not getting that gamed here, but certainly there's some chance of that going on. So that's the habit formation where we're rewarding our households for doing this good behavior. Okay. The learning part of it is something that I developed many years ago. And in essence, let me just show you what it is. So it's these two things, okay? So hopefully my pointy thing. Okay. Okay. So what happens is, okay, so first of all, it's low tech, right? It's paper and pencil, okay? And it's very simple and it's very visual. So that's something I want you to sort of note first, right? It's calibrated for a low literacy, low tech environment. We're keeping it really simple. And all it is it's getting every couple of weeks, our health worker goes into the house to a household, and we sit down with the mother and we say, okay, in the past 2 weeks, amongst your children, how many diarrhea days were there? And so they mark on a bar chart how many there were. And along with that, so in the red, they mark their levels, and in the blue, we've got a community reference level. We've got that from our pure control group, right? Like we've got a reference level for number of diarrhea days you'd expect. Okay, so we have a reference that they can compare to. So we do this, and this is going on for a period of about three months. We do this. Every 2 weeks we go in, we get them to record, do this visual record keeping. So they're noticing, they're finding out what their levels are, how they track compared to the community. 3 months out, we start giving them chlorine. They continue to use this tool, this info tool, okay? And at the end of 6 months, sorry, I'm so afraid of walking away from this thing. At the end of 6 months, we get them to compare their levels before using chlorine and after using chlorine, okay? So we compile all that data that they collected themselves and marked themselves, and then we get them to make a little comparison before and after. So that's what this info tool, the learning intervention is. It's like, it's notice what's going on, the disease that's going on, and notice if there's any improvement for you. That's what we're trying to do. We're trying to make this obvious to them. How am I doing on time, by the way?
Like 2 minutes.
Oh, gosh. Okay, so timeline-wise, here's what happened. We started last year. We started in May. We had our baseline. We did 3 months of what we're calling a pre-treatment period. That's when this info tool was. We did 3 months of info tool. Nothing else was going on. Then we had a treatment period of 3 months as well, where chlorine distribution began. We started offering free chlorine to people. The info tool, the learning group, continued to use this tool. Now that they've got chlorine access, they continue to use it. They see the difference that makes. The incentives group started to have the incentive given to them, right? That they were being rewarded for their good behavior. And just to be sure, we're keeping all arms income neutral. So we did offer the info tool and the chlorine only the average value of the prizes that the incentives group was picking up. Okay. So after this 6 month sort of intensive interventional period, we have this post-treatment period, which we're in right now. And next month, we'll have our an end-line survey. Okay, so in terms of the results, what's really nice is we've got such a rich temporal stream of data. We regularly measure chlorine in drinking water in these households. I've got 1 more minute. And so the first one I wanted to show you was the chlorine only group versus the info tool group. And so you'll see broadly that, so there we've come out of the summer period, we entered winter over here, and we're now this is kind of summer again, the high diarrhea period. Broadly, you see that the info tool group is riding a little higher. If I statistically test, we find that it's about 2 percentage points higher on average in this post-treatment period, okay? So not way higher, but a bit higher. The difference between the incentives and the info tool, not so clear. Doesn't look like there's anything clear going on here. The other thing I wanted to show you was, self-reported diarrhea, so disease. In the post-treatment period, the info tool group has significantally lower self-reported diarrhea for children. That's as compared to the incentives group. This is the compressed table, but even compared to the chlorine-only group, it's lower. Okay. So they report lower diarrhea. That's great. That's a good health outcome. In terms of decay, where you started and where your trajectory, we find that the info tool group, the learning group, has way lower, has a slightly less steep decay. I'm being told to stop. So give me one last thing I wanted to show you. Okay, so So the final thing, let me show you is this. So what's going on in terms of our learning? So there's two sort of things that we explore. One is individually for you. If you're looking, you get this data from this info tool. How do you respond to it? And so what we wanted to look at were people whose health improved having used chlorine. Do they tend to use more, right? Like that's the group that really benefits, or at least obviously in an obvious way. So what we found was that, what you're looking at is the dark line that rides above the dashed line. It just says that broadly, the people who looked like they benefit, who saw the benefit most obviously, tended to ride higher than those who didn't see it. Okay, so that's one form of learning that's going on. The other thing is neighborhood, right? There's people around me who are also learning and who are also using chlorine. This was an individually randomized treatment. So there's people in my neighborhood who are using chlorine and learning from it. And so what we see is that as you get more participants in the learning arm around you, if I'm a learning person, like if I'm in the learning arm and I have more households in my neighborhood in a 20-meter radius who are also learning households, my propensity to use chlorine increases. So there's a couple of pathways here that might be occurring with the learning. So I'll stop there.
Thank you so much, Ali, for the presentation. Maybe we just need one or two questions. We're running out of time for the session.
Obviously, don't.
Thanks, Ali, for the nice presentation. Just one question, not related to health, but related to self-evaluating sheets that the community was filling.
Yeah.
Did you observe any change in the regularity or accuracy of self-reporting done by the community over the weeks or months that you did this exercise?
So the thing is that this is all self-reported and we are in that 2-week recall window. So the recall was driven by our health worker going in and sitting down with a mother and saying, okay, tell me in the last 2 weeks what happened, right? And then they record this. So the accuracy is whatever the respondent tells us. It remains that accurate. If you're asking over time, did it become better? I don't know a great way to measure it, but I bet you that's probably what's going on. Now you're looking at this more, right? Like you're more aware that, oh, this is what we've showed them the Bristol stool chart, right? That shows you what you're looking for. So clearly our participants are more aware. They are looking for it. So presumably the measurement got a bit better, right? So yeah.
Only one more question, and we'll park at the end for all other questions.
Thank you. That was very interesting and well explained. And I'm just wondering whether you would expect to see a difference between your arms. Your residual chlorine levels did look particularly different. And then I guess I'm wondering your comments on the difference in the self-reported diarrhea outcome, whether you think that could be due to a differential bias between the eye due to the different type of intervention that was going on. So I'd just like your comments on the interpretation of that.
That's a really good point. So we've, like for the learning arm, maybe we've just shifted how sensitive they are to seeing it, and so or how they perceive it. So somehow we've shifted their ability to measure it. I don't know. So I think the answer to that will come with our end line, where some objective form of measurement for this will have to occur. We have some thoughts on that. I welcome any ideas you have, but it'll be some kind of recall, again, self-reported recall. Just to say again, we did the information on how you identify diarrhea was the same across arms. Everybody was given that and shown that Bristol stool chart. So our hope is everybody is equally sensitive, but I agree, you're right. The learning arm, every chance that now they're somehow more sensitized or looking at it differently, right? So you're right, yeah.
Thank you.
Thank you so much, Ali. I think this is really interesting for us to learn about the experiment. And moving forward for our next presentation will be from Mr. Alauddin from ITN-BUET about sanitation intervention and women empowerment, a comparative assessment of two cities in Bangladesh. We have 10 minutes for including Q&A. My name is yours.
Thank you. I'm Alauddin Ahmed, also presenting on behalf of my co-authors, Ms. Afia Jahan, Nita Hussain, Ms. Makki Farah, and Dr. Tanvir Ahmed, also present in this room. And of course, I have 60 slides to cover in 12 to 15 minutes of time. And the amount of jet lag I'm having, I can sleep in between. I'm sure you'll be waking me up for that. Let me say, mainly the slides will cover a little bit of background. I won't focus on the methodology, as I mentioned, don't have much time, but the slides are here. If you have burning questions, I can just share in the slides and discuss as well. The results and discussion, I'll try to focus on that, and finally some conclusion and way forward. Now, if you see the background, of course, safely managed sanitation. The inadequacy is there in the entire developing world, also in Bangladesh, and it is disproportionately affecting women, particularly, of course, worse circumstances impact women, but we don't have much data on that. It is vice versa as well, how women's empowerment is impacted due to WASH interventions. And of course, whether WASH specific measure, whether those have any linkage with empowerment or not. Now, in our country, we had the opportunity to have two approach, or rather two studies, I would say. One is the citywide inclusive sanitation. You must have heard, very hugely promoted in some of the parts of the world, where it looks for the city dwellers, the urbanizations, safely managed sanitation for all. And it is not technology specific, of course, a mixture of technologies can achieve that, and following the entire sanitation value service chain. The other approach or conceptual model that is available is the measuring urban sanitation and empowerment. We also shortly known as MUSE, that looks for expansion of choice and strengthening of voice, and that is through a transformation of power relations. So women and girls have more control over their lives and futures. So both these studies actually carried out in Bangladesh into small towns or cities. One is Soyodpur, another is Meherpur. So those are the study areas. And I'm glad I can see Madeline is present in this group. So if you have any question on news, I'll just definitely make you transfer to that direction. It will also save me some time as well. The study was carried out in 2002 in Bangladesh, and the sewage potentiality assessment, it was carried out also in 2002 in 10 towns. But fortunately, we had also these 2 towns part of that study. So that actually combinedly enabled us to prepare this paper, whether one has any effect of other. And the objective was definitely to evaluate sanitation-related empowerment factors among women in Meherpur and Soyodpur municipalities through use, and examining the temporal correlation between empowerment factors and duration of sanitation interventions, whether they have any effect or not. Now, as I said on methodology, I won't pass much time, just to make you aware. For the sewage potentiality assessment, the target was to assess the cities whether in terms of sewage were they present. This was the entire intervention design. What I try to focus here is the 3x3 sewage framework. On that, we have 130 plus questions and indicators. Based on the indicators, the questions were provided to the cities, and the cities were ranked based on their responses on these questions. Not detailing about, I'm sure some of you already have idea about the sewage functions and outcomes, equity, safety, sustainability, and the responsibility, accountability, and resource planning management. There were group of indicators we call principal indicators and sub-indicators there. Based on that, there are questions on city profile, solid waste management, sanitation, fecal sludge management, and of course, different development plan, master plan, and budgeting for sanitation as well. Now the MUSE, of course, it aims to create and validate measure of women's sanitation related empowerment, focusing on urban context, and it has three domains: the agency, resources, and institutional structures. And all these domains, definitely there are multiple subdomains and questions. I'm not again going through all these because of the time. Okay. Now, the data collection, there was two preconditions of data collection. The women will have to be adult, of course, and respondent has to be a permanent resident in the urban settings where they are belonging. It was snowball sampling and close-ended questionnaire. Now, the study area in Soyodpur, the question, the number of respondents was 729. Actually, the number of respondents was higher, but those who have the responded validated and took. Similarly, in Meherpur, the number of respondents was 720. So you can see it's a quite voluminous number of respondents. But what is more interesting about that is the number of questions per respondent was more than 350 plus. So we can imagine the amount of effort that need to be put to complete this study. And in all these three domains, the questions are there. I'm not again going through details, but demographics covered, the city-specific items covered, COVID-related questions were there, and outcome measures. In addition, the sanitation, water, administration, validation, and covariates and prioritization questions are also part of this study. Now let's come to the findings. The primary findings from the sewage intervention that we had, of course, both the municipalities Class A municipality, which means they are in term better compared to Class B and Class C municipalities that is available in the country. In the area-wise, Meherpur is little smaller, 17 square kilometer compared to Soyodpur, which is 34. In terms of population, as you can see, the total population is more than 140,000 in Soyodpur, with a 68,000 female respondent, and it is around 70,000 in Meherpur with 35,000 female respondent. One important thing here is the LIC population. As you can see, in both cities, the LIC population is very close. One is 40%, another is 35%. Okay. Now regarding the sanitation coverage, the basic sanitation coverage in Soyodpur is 100% and Meherpur is 75% compared to 40% LIC coverage in Meherpur and 90% LIC coverage in Soyodpur. In terms of intervention starting point, I'm not sure whether I mentioned in Soyodpur, the intervention started in 2013 and Meherpur in 2017. So there is a 4 years gap. The intervention started in both the cities. From the MUSE studies, as you can see, the demographics and respondents' age profile. Again, I'm not stretching that. Education profile, it is, you can see not received education is around 7% in Soyodpur compared to 6% in Meherpur, so not much difference is there. In terms of income generation, as you can see, no income generation women is 79% in Soyodpur compared to 68% in Meherpur. So that is there. Now let's come to the effect on sanitation. As you can see, the intervention time was higher in Soyodpur, and their private sanitation facilities for women was also higher, 93% compared to 83% in Meherpur. And if you see in a latrine available in own yard or plot, it is 57% in Meherpur compared to 86% in Soyodpur. So there is also a change, as you can see, due to the sanitation intervention. Now, the toilet facilities. In our today's plenary, we heard sanitation is about dignity. But here you can see whether a toilet is lockable or not. There is also a change in Soyodpur in Meherpur, quite a significant change compared to 94% to 85%. And lighting is, there is also different in that. So In terms of water for sanitation, actually, not directly water. If you can see, 28% women needed to collect water for sanitation activities in Soedpur. And out of them, 4% need to pay for that water as well, not only collection. Compared to Meherpur, it is 33%. And out of them, of course, 14% need to pay water for use in the toilet. In terms of menstruation, 7% of women in Meherpur avoid income-generating activities during menstruation compared to only 2% in Soedpur. So that change is also there. Now, during COVID-19, of course, all of we were engaged in household activities. Definitely, women shared a more role in terms of sanitation, at least they reported so. So the cleaning sanitation location, they have to engage more in Meherpur, 38% compared to 25% in Soedpur. And other sanitation family needs related activities, there is also change, 26% in Meherpur compared to 70% in Soedpur. So in terms of fundamental outcome that I mentioned regarding the news, the leadership, as you can see, 40% of women in Soedpur and Meherpur have decision-making roles in the communities. That is because of the government rules. So that number is equal. But when it comes to Soedpur, is 9% more confident women that their voice is heard in the community meetings compared to Meherpur. That is also there. In terms of freedom of movement, the agency, nearly all the respondents in both the cities can use sanitation facilities without permission or any accompaniment of others. But a slight difference is there in terms of freedom of event substitute. As you can see, attending community meetings, trainings, or any outside events, they need permission. For Soedpur, it is 53%. And Soedpur it is 47%, Meherpur it is 49%. Now again, Soedpur reported higher frequency of conflict-free interaction with local leaders and regarding sanitation issues, so that the local leaders don't need to be convinced that much, which is 94% in Soedpur compared to 88%. Definitely, I'll have to stop very quickly here. In terms of resources here, also Soedpur, that in terms of LIC, they have more toilets in access in Soedpur compared to toilet. I will go to the comparison slide very just quickly. The temporal influence at a glance, let me show you for all three domains. This is the slide. So if you see the management, leadership, relation, safety, financial asset, and skill, everywhere there is a changes of sanitation intervention. And in terms of safety, of course, it is the highest, the 14.13% higher in Soedpur compared to Meherpur. So that's the conclusion. The recommendations are, of course, that we need to develop our intervention in such a way and manner, and keeping in mind that the intervention matters. Probably not the way you think about, but it also affects some other domains of the world, particularly women's empowerment. Thank you for patient sharing. And of course, I need to acknowledge the Bill and Melinda Gates Foundation, both the municipalities, also the DPH's Youth Education Support Cell. MORA is here with us for the community and water aid and practical action. Thank you.
Thank you so much for the presentation, Mr. Alauddin Ahmed. We have 1 or 2 questions maximum. If there's no question, okay, 1 question from the back.
Maybe I can start out.
This is for the participants.
Hi, well done. It was very insightful presentation. Just a quick one. As I was also based in Bangladesh for some years, and I know I could relate some of the findings. I was just wondering about when you say the permanent residents of Soedpur is really open to migrants. How did you come across when you selected those participants when you said the kind of permanent residents?
Okay, as you see, the sampling was covered snowball method. So all sort of groups were part of that group when we selected that. That includes the migrants, but not migrants who are residing there, not residing there permanently, because some of the migrants are residing there permanently, others are temporal. So those are not part of the intervention.
Thank you so much. This is a really interesting presentation. I personally have my personal questions, but because of time, we need to move for the next presenter. From Care International, please. We have Ms. Manyashal and Ms. Miraj about to present about measuring and addressing structural barriers to gender equality with the Federal Ministry of Water and Energy from Ethiopia. I'm sorry for the technical problem. We're meanwhile, with interest of time, could you please explain a bit about the project and while we are fixing the tech problem? Thank you.
Thank you very much. Good afternoon, everyone. So we'll be speaking on the project called Seizing the Moment, where we worked with the Ministry of Water and Energy to ensure that they provide equitable wash services in the community and on different levels. This project is funded by the Hilton Foundation. It was a pilot project. We implemented the project in 1 year, and we conducted different activities, including baseline assessment and also providing different trainings. But we'll be speaking on the methodology that we utilized and also on the learnings through our presentation. Thank you very much.
Okay. Thank you, Mr. This is Manisha. Good afternoon, everyone. I also work for Care in Ethiopia on food and water systems. As Nusrat mentioned, we are trying to work on a pilot project that was financed by Hilton, Hilton Foundation. As you know, for those of you who don't know about CARE is a development organization that works around the globe to save lives, eradicate poverty, and social justices. It's also one of the leading NGOs on the WASH and gender transformation programming in Ethiopia. Seize the Moment is a pilot project that we are talking about. It is about strengthening the Ministry of Water and Energy in addressing gender in its organizational culture, staff capacity, and policies. It's also about strengthening its link with the Ministry of Women and Social Affairs, which has got the greater mandate in gender equality or making sure gender is integrated in all the programs in the ministries. It is very much aligned to our vision, and it advances our CARE's vision of 2030, and also the Hilton Foundation's goal of working and believing in the national government's ability to plan, design, and implement water systems. So why is it important? Why this project is important? Because sustainable and equitable wash services require the commitment, engagement, and involvement of local governments. But in reality, the reality is far from this fact, because very few actors, integrate address structural barriers of gender inequality and women leadership. So we believe that lessons from this program, will influence how sector actors understand approaches and in the WASH and increase their impact and scale. We also believe that lessons are replicable by other sectors, which have got greater contribution to the different SDGs like reducing poverty, gender equality, clean water, what have you. So the rationale, if Ministry of Water and Energy and its regional bureaus have the knowledge and the will and the capacity to implement gender transformative approaches, that means that women and girls will have equitable WASH services. That's why our gender transformative approach is not always about service delivery, but making sure the root causes of gender inequality are also addressed so that women and girls will have access to solutions and their lives will be improved. So just to say that while we understand changing gender norms takes time and it's a gradual process, but in this pilot project helped us to do some potential activities. One, we have been able to collect critical baseline data to understand the challenges and opportunities with the Ministry of Women and Energy. For example, we realized that as an opportunity, there is a gender directorate in the ministry, but that gender directorate has no budget at all. Two, we have assigned a dedicated team to take the Ministry of Women and Energy staff in this pilot journey. And thirdly, we have been able to provide transformative trainings starting from the top level. These trainings include like self-reflection and staff thinking to say, if I do this, that means I can do more in these areas and so. The other thing is we have not been doing this alone, but we have bring on board sector ministries like Ministry of Women and Social Affairs, Planning, and also the finance, who always have a role and the mandate to review and approve plans of the ministries. And finally, we have been able to support the revision of the governance leveling tool. The governance leveling tool is like a gender marker where they have been reviewing their plans, whether they are contributing to women empowerment and so on. But by supporting the revision of this tool, we are saying that they have to go up to the transformative level as well. So the rest, Ms. Raj will tell us more of the details on this.
Thank you again. So I will be speaking on the key results of the pilot program. So as mentioned earlier, the pilot program enabled us to foster buy-in from the senior leadership of the Ministry of Water and Energy, especially on strengthening gender budgets and plans, and also examining its HR practices such as recruitment, retention, and promotion of female employees, thereby addressing the poor gender parity within the ministry. So one of the key success of the project was the launching of the leveling tool for the first time within the Ministry of Water and Energy. It's, as Mandy mentioned, it's like a gender marker, but the previous tool was up to gender responsive, but because of CARE's strong advocacy, now the tool has a gender transformative pillar. And so the tool actually was used by the Ministry of Women and Social Affairs. It's like an accountability tool that they utilize to hold different line ministry offices accountable for gender outcomes. I will be speaking on the results on the key findings of the assessment on the next slide, but the leveling tool helped us to have a baseline information and at the same time engage the Ministry of Water and Energy on the need for greater gender equity. So the Ministry of Water and Energy scored around 68%, which is very gender low aware. So the results from the assessment include the first one is a limited understanding of gender equity and gender concepts by many stakeholders within the ministry. So there is a tendency to consider gender as serving an equal number of men and women without necessarily analyzing the gender power dynamics and also the barriers from providing equitable wash services. Another key finding was weak translation of high-level gender commitments into actionable plans. For example, the national water policy is somehow gender aware, but when it comes to the annual plans, they don't have any kind of gender key performance indicators. Another key finding from the assessment was the ministry is struggling to integrate gender into its work because of different reasons. One is lack of technical capacity, limited resources, and limited expertise. There is also lack of gender disaggregated data to help officials within the ministry plan services and track outcomes. Another key finding from the assessment was insufficient women's leadership in WASH committees. Currently nationally, only 90% of the WASH committees meet the criteria of having 50% of women as members. Another key finding was lack of ownership and accountability for gender ministry. So there is a gender unit within the ministry, and they are responsible for supporting the different units to integrate gender into their work. But currently this is non-existent, and they are not held accountable for not doing that. And also the different units within the ministry, they are also expected to integrate gender into their work, but they are not doing that, and they are not held accountable. So there is no accountability mechanism. And lastly, there is limited gender-specific budget allocation. So the leveling tool assessed the 5 years budget of the ministry, and only 0.02% of the total budget was allocated for gender mainstreaming activities. And women make up only 12% of higher leadership and 27% of middle leadership. So because of the assessment and because of the evidence, the Ministry of Water and Energy is taking concrete actions. One is to provide gender training, to increase understanding of gender equity, change staff attitudes, and help staff incorporate gender into their work. They're also developing action plans to include gender key performance indicators in their annual plans, budget, and strategic documents. They're also keen to collecting and analyzing gender disaggregated data on equities at household and community levels to inform service design and monitoring. Organizationally, they are also keen in revising HR policies, thereby shifting culture to increase recruitment and promotion of women. And another key action is to work with communities to change gender norms to increase women in WASH committees. Lastly, they're planning to institutionalize a system that supports greater accountability for gender integration. So our key takeaway from this project or a recommendation is that achieving gender WASH services requires structural change within the government, such as the Ministry of Water and Energy, who are responsible for WASH services, and organizations such as CARE can support this structural change with tools, technical expertise, training, and accountability mechanisms. Thank you very much.
Thank you so much for such great presentation, Ms. Mangyamshal and Ms. Ross. Do we have questions from the audience? Yeah, one, we probably only have two.
Thanks for that great presentation. It was really wonderful to see the ministry take direct action based on these results. And I'm wondering if there were any tips or tricks that you found, because I think often see in the sector that data itself is not sufficient to generate government action. So what do you think made it work in this case?
So the evidence really worked very well because, previously they don't have that kind of evidence, to show a commitment in improving their status in everything and also ensuring gender equity at the community level. One is the evidence, but second is showing sharing our experiences in terms of gender transformative programming, how it can also alleviate the challenges that they face in terms of ensuring women and men have equitable accesses, so sharing the expertise and also building strong relationship with the ministry officials. It requires some kind of navigation because they have their own political affairs, but from the development perspective, we need to show them that we are their allies. We're there to support them and build a friendly kind of relationship, but also navigating the formal structures and everything. So evidence, building strong relationship, and also sharing expertise can help.
If I may add also, we have not been doing this by ourselves only, but we have also been bringing on board the Ministry of Women and Social Affairs, the Planning Minister and the Finance Minister. So all the ministries are working together. They have put different forums and share experiences and everything. So bringing their own allies in the platform also helped a lot.
Thank you so much. We have one more question. If there is no question, I have a question. What is potential challenge you foresee in the future for the implementation of the plans you have presented? Okay.
Yes. Definitely, I would say a resource because most of the funders, I think they are very much keen in having different kinds of programs. But when it comes to ensuring gender equality, it's a kind of difficult to find a resource. But we're very much thankful for the opportunity that we got from the Hilton Foundation. They saw the potential that the project have on ensuring that women and men have equitable access to wealth services when you work with structures such as government offices. So one is a resource, another is working with a government institution. It's very challenging, and there are turnovers. And also, the formality and everything. But yeah.
Thank you so much. We have such a presentation today. We only have 2 more minutes for one burning question for either one of our presenters. If we don't have to summarize, I think today we learned a lot from household level behavioral change intervention in Pakistan. And then we learned about how difficult it is to support midwives during the chaos of delivery in Cambodia and how it's still a big of challenge for postnatal intervention. And then we learned also how important for citywide intervention in Bangladesh, that intervention for sanitation isn't only impact sanitation access, but more agency and empowerment for women. And lastly, we learned about the importance of uptake from the government to ensure the sustainability of our intervention in behavior change for water and sanitation. So applause for all our presenters. And thank you so much for all the participation and looking forward for the next workshop. Goodbye. Thank you so much for today and for understanding about the
But it's like, very difficult, like I think Islam is the wrong word for it. It really is disconnected from service. I don't know. Okay, I was just wondering if no, so this is it's called current. The big don't know where this is from. I am basically from Delhi, but I am living in Ahmedabad for the last 10 years.
So I'm trying to.